Hi everybody, it's Dr. Austin Perlmutter. This video is on the molecular mechanisms of depression. I've been spending a lot of time in the last couple of years thinking about depression and learning about depression. There's so much to understand about the mechanisms at play in this condition that are not well understood. And, I think we tend to distill down the idea of depression into a very basic issue of the mind when there's so much more going on than meets the eye. We now know through scientific research that there are mechanisms at play in depression that go from the molecular to the structural to the connectivity to the psychological all the way to the societal levels. And all of these mechanisms are important. In this video, I want to focus specifically on the molecular mechanisms of depression. I will start with some of the basic context and background on depression. I'll give a little bit of historical background as to how these molecular mechanisms came about, why we believe these ideas at all. And then I'll talk about some of the newer science around things like molecular pathways of immune activation that seem to play a role in depression. We'll talk about synapses and some of the receptors and neurotransmitters that are involved there. And we'll talk about things like hormones, insulin, estrogen, and how these feed into our current understanding of what appears to be going wrong in the brain with depression. We'll finish out this video with a description of some of the ways that you can start applying this more recent science into strategies for depression. Depression is a strange thing. It's a term that gets thrown around a lot, but it has different meaning depending on if you're having a day-to-day conversation about how you feel, or if you're in a medical office and you're going through a depression inventory. So in the medical context, we really abide by these diagnostic criteria. You either have depression or you don't have depression. But in the real world, it's obviously not as cut and dry and black and white as that. The truth is that all of us experience some depression. It's just a question of how do you look at it. Our mood is not a straightforward 5 out of 10 as far as how we feel each day. It goes up and down. And these up and downs, this contrast between a good day and a bad day, a good hour and a bad hour, it's necessary, right? That's what gives us the spice of life. It lets us experience the highs more when we have the lows for contrast. All of us are in constant flux, and that's at a physical level, a molecular level, as well as an emotional type level. When things become problematic is when the downs significantly outweigh the ups, when we get stuck in the downs. As Alan Watts said, the more a thing tends to be permanent, the more it tends to be lifeless. And in fact, depression is a mental state which is characterized by more rigidity, less flexibility in our thought patterns, and specifically more rigidity that locks us into negativity and pessimism. So it really is, in the way that I see it, is a state of stuckness. This stuckness can be conceptualized at multiple levels. You have the level of our neurochemistry, the level of our neuroanatomy, the level of our psychology, and even the larger social or societal level. So in this video, we're going to be focusing specifically on the molecular level of this depressive stuckness. We'll be discussing neurotransmitters, we'll be discussing molecules like BDNF and estrogen, insulin. BDNF, by the way, brain-derived neurotrophic factor. You've probably heard that term before. There's a lot of really technical information as it relates to these molecular pathways. I'm going to try to keep this video a little bit more user-friendly, but if you find that you're interested in this and you want to learn more about some of the more nuanced science, I'm happy to do those videos. Just let me know, post on this video, and I'll be happy to put that out. Let's begin with the basics of what depression is. There's depressive symptoms, which are, I think we all kind of understand, just feeling a little bit off, a little bit of worse mood. And then there's textbook depression, what we call major depressive disorder. And that's something that really has to be diagnosed by a specific set of criteria, which are outlined in the DSM-5. You have to have anhedonia, or depressed mood, and then you have to have 4 other symptoms. And these are things like significant weight loss, a decrease in appetite, slowing down of thought, a slowing down of physical movement. You have to have fatigue or loss of energy, feelings of worthlessness, a diminished ability to focus, or suicidal ideation. And it's thought that across the world, about 10 to 20 people over the course of their lives will meet these types of criteria for major depression. What do we currently do for depression? I guess it depends a bit on the culture and country you live in, but specifically in the United States, what do we do? Well, many people don't actually seek help at all. They kind of deal with these symptoms on their own. But if you do go and see a traditional physician, or I guess a conventional physician, you are kind of going to get slotted into one of two treatment arms, and those definitely overlap. Those include psychotherapy, things like cognitive behavioral therapy, and then pharmaceuticals, antidepressant medications. There are other treatments too, so there are things that range from transcranial magnetic stimulation to electroconvulsive therapy, ketamine, and the like. We'll touch on those briefly, but for the most part, we're talking about more traditional antidepressant medications, things like SSRIs, SNRIs, and then a little bit less likely, but sometimes use things like tricyclic antidepressants or TCAs, and then there are some newer medications too that overlap between these categories. I think it is important to note that there is a component to relapse with depression that is quite significant. If you've had an episode of major depression, your chances of relapse are 50%. If you've had 2 episodes, it's 70%, and 3, it's 90%. We also know that even with the best treatments we currently have available, treatment failure is around 30+%. And as I mentioned before, that kind of comes from data from the STAR-D trial, which looks at treating people with multiple rounds of antidepressants. So let's now get into the molecular pathways, the questions of how do our treatments work. And we'll be, in this video, focusing on the pharmacology piece, or I should say more the prescription antidepressant medications, and less about the molecular pathways that are involved with things like cognitive behavioral therapy, which are interesting but are harder to pin down. So how do we get this idea that we should be treating people with drugs for depression? Well, it turns out that around 100 years ago, researchers were experimenting with the molecule histamine. And you probably know histamine because it's involved with having allergic reactions. A lot of our traditional anti-allergy medications are antihistamines, things like Benadryl, that they dampen the histamine-based response. So again, researchers were messing around with histamine and various molecules that changed histamine in the body. And what they found is that when they were using these types of drugs, some people got some antipsychotic benefit. And so they continued to experiment with this, and they eventually created a drug that also had some antidepressant benefit. And this became the first tricyclic antidepressant medication. And then similarly, they were also working with medications to treat tuberculosis. And what they found is that these medications had an antidepressant effect as well. So this drug that they were messing around with became the first monoamine oxidase inhibitor, or MAOI, which is a class of antidepressant medications we don't use as much these days. So that's where we started out with these antidepressant medications, and then a little bit more recently, around the 1960s, they found that serotonin was also playing a role in depression. They thought that depressed people tend to have lower levels of serotonin in the brain, and this was from experiments where they found that supplementing with tryptophan seemed to improve depression in certain people. Tryptophan is converted into serotonin. So that then led to, as you're probably aware, the advent of the still most prescribed medications, the SSRIs. The first SSRI was Prozac. It was released back in 1987 and became a huge blockbuster drug. But all of these medications that I'm describing kind of operated on this hypothesis that in people with depression, there was an imbalance in what are called monoamines. And monoamines are so named because their structure, a chemical structure, is a singular amine. But monoamines include multiple classes of molecules. Specifically, catecholamines are the ones that people generally think about. Those are norepinephrine, dopamine, epinephrine, things like that. But it also includes serotonin. The idea here is that, again, people with depression have an imbalance in their monoamines. Specifically, they tend to be lower in the places where they need them, which is in the synapses between the neurons. And so the medications tend to increase levels of things like norepinephrine, dopamine, serotonin, and the like. And these are different depending on the antidepressant you're looking at. So, for example, antipsychotic medications, which can sometimes have an antidepressant overlap, can actually have opposite effects. But for the most part, we're talking about increasing things, specifically serotonin, in the synapse, the space in between neurons, so that postsynaptic neuron is getting more serotonin, because it's thought that a serotonin deficiency is involved with the feeling of, or the experience of, depression. So what about the monoamine hypothesis has actually been validated? I mean, this is still kind of the standard idea as to what's going on in depression. So monoamines are depleted or altered, and specifically serotonin is depleted. Well, what they found is, again, based on these early trials and then based on subsequent trials conducted with these serotonin-based therapies, that they tended to work. So these drugs that elevated, in theory, brain levels of serotonin were associated with people having less symptoms of depression. So it was thought, okay, well, if these drugs lower or increase serotonin and people get better, that must be the mechanism at play. There are animal studies where they look at the levels of these chemicals in the brain, and usually animal studies because you don't want to carve up a human's brain to see if that drug is working, where they can show that these drugs do tend to increase things like serotonin in the brain, but not so much in humans. We're not really so sure that serotonin levels in humans in the neural space or the synapse are as elevated as we might like to think. And then the other kind of bigger issue with this monoamine serotonin-based hypothesis is that if you're prescribing a drug that we know is supposed to increase serotonin in your brain rather quickly over the course of hours, why is it that we give people 4 to 6 weeks before we expect to see a benefit to these drugs? It doesn't seem to fit with the mechanism. And then there's also the clear data that a lot of people who are taking these medications don't get a benefit. That even after multiple rounds of these types of therapies, around 30% of people don't really get a significant benefit. So if it was as simple as just a serotonin problem, this wouldn't really make sense. There's also research that shows that when you take healthy people who don't have depression and you deplete their brain levels of serotonin, by giving them a specific drug, it doesn't really cause depressive symptoms. So there's not necessarily as much evidence as we'd like to have that the monoamine hypothesis, and specifically the serotonin hypothesis, explains what's going on in all cases of depression. In more recent years, there's been a push to continue to explore what might be going on in cases of depression that is beyond just serotonin, which is great because obviously this framework was not sufficient. And I think that of the theories in this vein of new research, the most prominent appears to be that depression is characterized by problems with neuroplasticity and neurogenesis. There's basic evidence in humans showing that the prefrontal cortex and the hippocampus, prefrontal cortex sits behind the forehead, involved with higher level cognition, hippocampus a little bit deeper in the brain, involved with a lot of memory, but also with a variety of other functions. But in any case, that both of these regions of the brain show atrophy. So you have decreased volume in both of these areas of the brain, and that correlates with the duration of depression as well as the severity of symptoms. So researchers thought there's something going on here. And really what they're looking at here as it relates to neuroplasticity and neurogenesis specifically in the neuroplasticity component, is that there are changes happening in the synapse, because that's really where neuroplasticity takes place. The synapse is the space in between neurons. It's where neurotransmitters flow out of one neuron and then go to the next one and send the impulse throughout the brain so that that signal is able to be transferred from one neuron to the next. And what they've shown is that in people with depression, there's actually decreased expression of synapse-related genes in the dorsolateral prefrontal cortex, which is one of the parts of the prefrontal cortex that's located dorsally and laterally, so up on the top and to the side. At a molecular level, they've basically said that there are a couple of key receptors that are involved with this synaptogenesis, or I should say, neurologic plasticity or neuroplasticity. And these receptors are AMPA and NMDA. These are receptors that are involved with long-term potentiation and long-term depression, which is kind of getting technical here, but these are the mechanisms by which people think the strength of the connection between neurons is either strengthened or weakened. And so it's thought that in depression there are changes with these types of receptors, and in the case of some of the newer therapeutics, specifically with ketamine, it's thought that some of the rapid-acting antidepressant effects actually act through these receptors to increase neuroplasticity, and that may be why people who use ketamine for depression get benefits to their depression that happens over the course of several hours, as opposed to, in the case of something like an SSRI, taking 4 to 6 weeks. So it kind of adds to the evidence that maybe it's more of the neuroplasticity mechanism than it is the serotonin mechanism. What I think is absolutely fascinating about this neuroplasticity, neurogenesis type hypothesis for depression is that it enables us to pull in research from things like metabolism and the immune system into a more connected model of what's going on in the brain in mental health conditions. So researchers have kind of postulated that various molecular pathways are involved in this, and so we'll go into some of those now. As it relates to the metabolic piece, it's thought that the insulin pathway and insulin like growth factor 1 may be involved because these are molecules and molecular pathways that promote neurogenesis. And so what we know is that there's a whole lot of concern now for insulin resistance. Insulin resistance throughout the body causes its own problems and is linked to metabolic syndrome. Insulin resistance in the brain, which is characterized by a decreased availability of insulin and a decreased ability to use insulin within the brain, and may be problematic because it decreases the energy that the brain is able to use, since it's no longer able to get the glucose in because it doesn't have the insulin to help bring the glucose in, but also because insulin itself is a growth factor for the brain and helps perhaps support neuroplasticity. What this all means is that the increasing incidence of metabolic syndrome and its associated insulin resistance and problems that accompanies visceral adiposity, or I should say just general obesity, accompanies high blood pressure, that this may actually have an overlap with depression by way of these insulin pathways. And there's a lot to talk about there. I won't get into it in too much detail, but the basic idea is, again, that you need insulin in the brain. You need the action of insulin in the brain to support it metabolically. You also need it as a growth factor to support neuroplasticity and neurogenesis. And the increasing incidence of insulin resistance, which is associated with things like obesity, may be playing a role, therefore, in depression. And we do know that there is a decent link between obesity and depression, between fat cells, specifically visceral fat, and depression. And so this leads to the next and perhaps the most interesting component to all of these molecular mechanisms, which is what is the role of the immune system in this neuroplasticity, neurogenesis piece? And as I've discussed in my prior videos, and hopefully as you're starting to learn by now, there's a lot of research that associates inflammation, which is an altered state of immune balance, with depression. So specifically what we know is that when people have higher levels of inflammatory markers in their blood. These are cytokines or molecular signals from the immune system, that they have a higher chance of developing depression. And we also know that people who are given an inflammatory challenge, something called endotoxin, which increases inflammation in the body, experience symptoms of depression. So now we think that it's probable that inflammation may cause certain types of depression. And we know that this has a mechanistic role in these molecular pathways that I've described in the brain for neuroplasticity, because inflammation, as well as chronic stress, but inflammation appears to decrease this molecule called BDNF. And I mentioned this before. Why is BDNF so important, though, is because BDNF is, has been said by my dad and others, is like Miracle-Gro for your neurons. That is a strong promoter of this neuroplasticity. And when we don't have enough Miracle-Gro for our brains, when we don't have this BDNF, our neurons can atrophy and they don't have that ability to form the new connections the way that they might otherwise. And so inflammation appears to decrease BDNF, and inflammation also and chronic stress appear to decrease the neuroplasticity, neurogenesis in areas of the brain like the prefrontal cortex and the hippocampus, which could help explain the types of findings that I mentioned before, which is people with depression tend to have shrinkage in the prefrontal cortex and the hippocampus. One little caveat to this, which I think is important to note, I am not an anti-inflammation person. Inflammation is very important, and it turns out that these molecules, these inflammatory signals, may actually be essential in increasing neuroplasticity at low levels. But when you get to the levels that many of us are experiencing as a consequence of our poor health, that's where it becomes pretty toxic to the brain and decreases BDNF. One other point on this, to come back to the earlier mechanisms I discussed with insulin resistance. So we know that insulin resistance is strongly correlated with the levels of fat cells that we have, and really this visceral fat, which is a type of white fat and sometimes called belly fat that clusters around the belly. So it turns out that this visceral white adipose tissue, this belly fat, secretes higher levels of these inflammatory molecules, things like tumor necrosis factor alpha, interleukin 6, and interleukin 1 beta, and that these are the molecules that have been linked to higher risk of depression, and that these are the molecules, when found in the brain, that may be dysregulating and dampening that BDNF neuroplasticity pathway. Okay, so let's now talk about stress. What is stress? Certainly a topic far beyond the scope of this video, but what is stress as it relates to these molecular pathways? Stress is basically anytime there's a demand on an organism, and just like inflammation, it's necessary at lower levels and at certain times to keep us on our toes and also to enable our brains to focus. And so lower levels of cortisol and the like can help us to maintain focus and can actually activate the prefrontal cortex. Over time, chronic levels of stress, though, and elevated levels of stress also seem to decrease BDNF as well as to lead to this inflammation, which, as we've described, is seemingly directly toxic to the brain and increases our risk of developing depression. Let's go into a little bit of evidence for these different pathways, because I think it's important to note that this is more than just theoretical. So I think, again, the best evidence for these pathways relates to the inflammation, immune system activation, molecular pathway. And so what we know is that, as I said before, higher levels of inflammation correlate with depression. Giving somebody an inflammatory challenge correlates with depressive symptoms. We also know from large-scale analyses that anti-inflammatories, things like your typical NSAIDs, aspirin, Advil, and the like, that when people take those, they can actually lower depressive symptoms. And they're not taking them, to be clear, for depressive symptoms, but they're finding that people who take those long-term tend to have lower levels of depression. So there's a little bit of evidence there. We also know that when the levels of inflammation, as measured by interleukin 1 beta, decrease, so too do people's symptoms of depression. There's some interesting research that has been done showing that in people with elevated levels of C-reactive protein, which is another inflammatory molecule, that giving them a molecule, it's a newer molecule called infliximab, and it's an anti-inflammatory that specifically targets the tumor necrosis factor alpha pathway, these people will have improvement in their depressive symptoms. And how does all of this relate, again, to neuroplasticity and to depression? Well, there's recent research that looks at how inflammation changes pathways of neurotransmitters. And this actually comes back to the whole initial hypothesis, which was that serotonin levels are decreased. And so what they've shown is that there are these enzymatic pathways in the brain that convert to tryptophan, which is the precursor to serotonin, as well as to other things, into various molecules. And so what you have is tryptophan in the brain that can either go down one pathway and be converted into serotonin, or another pathway which can lead to creation of a variety of other end products. And some of those end products are thought to affect the synapse of the brain and could perhaps lower synaptic plasticity or neuroplasticity, which, as we've said, is kind of essential in our strategies for treating, preventing depression. So this is another technical discussion. Let me know if you're interested in it. I can break it down a little bit more. But the bottom line is that when you have elevated levels of inflammation in the brain and also stress molecules in the brain, it seems to shunt serotonin or shunt tryptophan away from serotonin and down these other pathways that may directly inhibit neuroplasticity. There's also really fascinating evidence as it relates to the serotonin kind of hypothesis, showing that these treatments, these antidepressants that we, I guess at one point thought were primarily targeting these molecules like serotonin and norepinephrine and epinephrine, actually increase BDNF in the brain and decrease levels of inflammation in the hippocampus, specifically interleukin-1 beta. So it may be that these molecules we've thought of as these very much in line with the monoamine hypothesis are actually working for the neuroplasticity hypothesis. Okay, I know we've covered a lot. There are a couple more points that I wanted to make. One, the hormonal pathways. We already mentioned insulin, but I wanted to have a brief mention of estrogen. And that's because we know that women are 2 times as likely as men to get depression, and this is associated with changes in estrogen and other hormones. We know that after menopause, levels of estradiol drop, and this parallels depressive symptoms going up. And we also know that estrogen itself influences neuroplasticity, increases BDNF, and can block some of those stress-related pathways that I've described before. So not to get into this in too much detail, but know that estrogen also seems to play a role in the pathways involved in depression. And then, I guess kind of lastly here, the microbiome. This is an entire conversation in and of itself, but we know that probiotics in multiple reviews have been associated with improvements in mood. We know that there's a decreased diversity in the microbiome in patients who are depressed. We know there's a decrease in, for example, Lactobacillus bifidobacterium and Firmicutes in people who have depression. And the molecular pathways that appear to be involved in this type of microbiome-mediated depressive influence seem to involve things like short-chain fatty acids, as well as gut immune interactions, and probably getting back to some of those inflammatory pathways that I talked about a moment ago. Okay, I know that was a lot, and I said it wasn't going to be too technical, and it may actually have been too technical. If so, I apologize. But let's bring this together as far as how do we take this science and create interventions that are evidence-based to inform our decisions around depression. The first thing I would say to anyone is the need to seek care. If you or somebody you care about is experiencing significant symptoms of depression, this really isn't something that you should try to deal with on your own. You should seek medical care. And I am a huge proponent of psychotherapy, specifically CBT for depression. But seeing a therapist in general is a great step. Also, talking to your provider about this as well. All right, so let's talk about how to perhaps target some of these molecular pathways that I described for depression. So We know that diet is one of the principal interventions that all of us can be working with to influence our health. And it's been shown in multiple large-scale studies that a Mediterranean diet, which is high in healthy fats, is linked to lower symptoms of depression. And I recently wrote an article on this subject specifically, which you can access on my website, austinperlmutter.com. But what we're talking about here is a dietary pattern that appears to lower inflammation, that appears to influence the microbiome. And this is really something that is also beneficial in a variety of other disease states. So a Mediterranean diet is probably a reasonable step for people who are trying to do everything they can to optimize their dietary intake to lower symptoms of, or perhaps even treat certain types of depression. There's also evidence that, as I mentioned before, the microbiome is involved, and so what can you do to improve your microbiome? This is a diet that is higher in phytonutrients, which is basically plant-derived nutrients that are not macro or micronutrients. You can also support your microbiome with eating fibers that are capable of being digested by the microbiome, and then as much as possible avoiding unnecessary exposures to things like antibiotics and other drugs that may be damaging to the microbiome. The reason the microbiome seems to be so important in this pathway is because it's involved with basically everything we've already described, but specifically inflammation. So your goal is to use microbiome support to improve your gut function so that you don't get as much inflammation coming through the gut and influencing your brain. Other things that you can do, I mentioned before that our fat cells are involved in these molecular pathways, specifically the inflammatory pathways, but also the insulin pathway. How do you get rid of fat? Especially, how do you get rid of visceral fat? The interventions here, of course, exercise, probably first and foremost, but also smoking, not smoking, also getting better sleep, also decreasing the amount of refined carbohydrates in your diet. These are practical interventions to help lower your visceral fat, which again may be a contributor to depression. And then we'll talk about BDNF a little bit. So what are things that we can do to improve our BDNF, to improve neuroplasticity? Interventions that have been shown to be associated with increased BDNF are things like consumption of omega-3 fats, which are found in fatty fishes, consuming EGCG, which is an ingredient found in green tea, curcumin, which is, you probably know, a powerful antioxidant that is found primarily in turmeric, coffee, even intermittent fasting. Exercise, again, comes up as a really potent intervention for increasing BDNF. Getting a bit of sun exposure, there's some evidence around vitamin D, and then just stress reduction. And so the final thing here is stress reduction. Definitely an important intervention for depression, and as I mentioned, there's kind of the direct pathway between stress and some of these neuroinflammatory issues that may decrease synaptic plasticity and therefore increase our risk for depression. But I think in the bigger picture, stress reduction is something that all of us would benefit from because of stress having a major effect on a variety of mental health conditions. Yes, depression, but also anxiety, as well as physical health conditions like heart disease and diabetes, and lots of things to talk about as it relates to specific interventions for stress reduction. I won't get into all of that in this video. Okay, so I hope this was somewhat interesting to you. To summarize, we're learning that the molecular pathways involved with depression may be a lot more interesting and expansive than just increasing serotonin or changing the levels of norepinephrine, dopamine, epinephrine in the neurons. And what we're learning is that along with this exploration of neuroplasticity, that there are things that we can be doing, differently with our lifestyle that can influence this neuroplasticity for the better, and that when we do these things, we may be taking steps to lower our risk for and even lowering symptoms of depression. Again, I want to reinforce the idea that if you are suffering from symptoms of significant depression, you should seek help. But to understand that all of us to some extent experience the highs and lows, and that there are things that we can be doing to try to optimize for a balance there so that we don't become stuck in the lows. I'm Dr. Austin Perlmutter. I will talk to you later.